pretty quickly, but just wanted to, as the agenda says, sort of the national landscape of really what's happening, but also the ground truth with what's happening in organizations like ours and in the MedStar system here in Fort Worth. So really, we're just going to literally look at the federal landscape or the national landscape, and I think Charlotte's going to do the federal landscape, but really what's happening and really what's the ground truth of the reality of the current status of the pandemic. And we often refer to the pandemic originally as the tale of two times. Really now it's almost a tale of three times, and COVID 1.0, 2.0, 3.0. And as you all know, the first phase of the pandemic, most of us saw a pretty significant decrease in response volume, decrease in transport volume, which then in many cases meant a decrease in revenue. At the same time, expenses were dramatically going up for personnel and PPE. However, that has now sort of reversed. And we're seeing that to a large extent now in COVID 3.0, where you've probably heard or experienced, if you're working with some of your clients, a dramatic increase in call volume. And our August, September, October call volume has been off the charts, certainly much higher than we had anticipated. Talking with a number of colleagues across the country, everyone is seeing that dramatic increase in call volume. And people can theorize, and we've done some data and analytics to see what types of calls are increasing, but it's likely a combination of pent-up demand, also a combination of people doing things that they might not normally do because they're finally glad to be out and about. It's still a lot of COVID-related cases. We averaged in September and October here in our system in Fort Worth about 110 to 120 patients per day that the crews were identifying as likely having symptoms that were COVID-like. And that's out of a response volume, as you see, of about 500 cases a day. So pretty significant volume in that regard. So that continues to be a real challenge. Now, to some extent, that has begun to level off. So the response volume in many communities has begun to, quote unquote, normalize. What's been interesting in our system, and several other systems have said this as well, is that even though the response volumes are increasing, the transport volumes are remaining relatively constant. In our case, the transport volume is actually down. So when we saw rising response volume, decreasing transport volume, that's likely due, and we know that it's due in our system, to a couple of key factors. One, we still have a protocol in place that if the patient is hemodynamically stable and has signs and symptoms consistent with the coronavirus, we do not take them to the hospital. So remember, if we're doing 110, 120 patient contacts a day where the crews think this patient has potential coronavirus, if those patients are stable and can be referred somewhere else, we're referring them somewhere else. So that's why the transport volume is down. Second, we are an ET3 participant model and one of the only 27 that have actually launched. So we're doing another 15 to 18 ET3 interventions for Medicare patients every day. And about 60%, 70% of those, given the day, are not being transported anywhere. Urgent care, they're being treated in place. So this dynamic, and John Washko from Northwell has done a great job depicting this, the advancement of EMS that we thought would take 20 years has happened in 20 months. And a lot of it's because of the challenges that were brought up by the coronavirus. And we'll talk more about some of the opportunities that has created here in just a moment. So that's sort of the dynamic that you see there. The challenge for every EMS agency across the country, and you can literally look at any newspaper, any national media outlet, any local media outlet, the EMS worker shortage is becoming a crisis. It is a crisis. And it is the number one topic at every EMS conference. It's the number one topic on our collaboration calls that we're going to talk about here in just a moment between the large national associations, but it is a crisis level. And everybody, all the national associations, all the local agencies are pushing for some type of quick initiative, no more white papers, no more research, no more any of that stuff. We just really need to fix this issue, either through system redesign, educational enhancements, stipends for people to go to EMS professional school of whatever level they want to go to. Because when you see these sort of record call volumes at the same time that we've got difficulty getting workers out into the field, either because they're off the clock because they have coronavirus or have a family member who's contracted it, because we've had a pretty significant wave, as you all know, from the Delta variant, and we're all holding our breath right now because we're starting to see in some states the wave coming back again, and we're going into holiday seasons and areas of the country where people won't go out as much anymore because it's too cold to go out, and they're going to be gathering in small clusters, and people are getting really nervous again that we're going to have a winter surge at a time that we really are having difficulty staffing resources to respond to calls. But again, in every storm, there's a silver lining, and we're going to talk about that in a moment. The EMS worker fatigue continues to be a significant issue, and quite frankly, the worker death continues to be an issue. We still hear, and it's in the national media and the regional media, about EMS workers, firefighters, and paramedics, EMTs, who are still dying from the coronavirus, and that includes law enforcement as well. So we continue to track this, and this is a link from the Kaiser report that they did with the Atlantic, and they're still tracking it. So we really need to watch that. What that does, however, is the publication of the stress and the worker shortage and the risks that EMS workers are taking, is it's leading to a higher turnover in our current workforce. And we'll talk about some of those in a minute, but our partners at the American Ambulance Association contracted for a great turnover study that just came out in July. And here are a couple of the stark realities. And across the survey, the people who responded to the survey, a 24% turnover in full-time EMTs and a 26% turnover in full-time paramedics. But then they also drilled down to find out why people are leaving. Is it just that they're going to another agency who is offering a sign-on bonus or a recruitment bonus of some kind? No, they're leaving the industry. They're making an occupation change, not just an agency change. And a lot of this is predicated from or driven by the hospital and the rest of the healthcare industry. The nursing shortage has led hospitals to be very creative with staffing, and they are recruiting heavily paramedics, because today in most states across the country, a paramedic can work in a healthcare setting, hospital, urgent care, freestanding emergency department, radiology clinic, you name it, at their full scope. So if you are a hospital CFO and you're paying $100 to $120 an hour for a nurse, but you can get a paramedic who, in many cases, from a technical clinical skill capability, in some communities can do more than a nurse can do in the hospital. They can administer narcotics, intubate patients, do the things that a full scope paramedic can do. And if you're going to pay them $50 an hour, that's a bargain for you. For the EMS industry, that's devastating, because we don't have the economic model that allows us to be able to pay paramedics $35, $40, $50 an hour, where the hospital systems look at it from an inexpensive nurse. We were just on a webinar a couple of weeks ago, and it was revealed that the University of Kentucky Health System, through using ARPA funds and other things, are currently paying paramedics $75 an hour to work in the emergency room at the University of Kentucky hospitals. And EMS agencies cannot compete with that. So they're losing paramedics because they're going into the hospital setting and doing other things. And let's face it, with the mass resignations that the country has seen in August and September, EMS is no different. And people are leaving the EMS industry and they're going into other industries, as that survey reported. And then you see ads like this. And Arby's in our community, Nebraska Furniture Mart is a big employer here. Amazon is a big employer, and they're paying $20, $30 an hour for warehouse workers and for other roles where you don't have to worry about getting out late from a late call. You don't have to worry about catching the coronavirus as much as you might in the back of an ambulance. You don't have to work out in the heat or the rain or the snow, or worry about getting broadsided by somebody while you're responding to a call and never going home to your family. And people are leaving to go into these other professions because it's less risk with better money than they can get what we're paying. And then you see Amazon doing ads like this that some of you may have seen in the national media.
I drop off and pick up my kids from school, so I can't work early or late. And I need to make enough to make it worthwhile.
I can only work 2 days a week, and it can't interfere with my other job.
I can do full-time, just not daytime, and I need benefits. Good ones.
And you know, it'd be nice if you paid for my tuition. Like all of it.
it is tough to compete with that when we hire people here and they say, I really don't want to work nights. I really don't want to work weekends. It's not convenient. But we're a 24/7 operation and you need people to be able to do that, but they can go work the schedule of their choice in a retail environment, and it just becomes more and more challenging. You've seen all the articles, you've seen a lot of those headlines, but this process started long before the pandemic, and the pandemic has just exacerbated it. And we knew 3, 4, 5, 6 years ago, this was going to be an issue. One of the bad things that has accelerated that we thought would take 20 years and has taken 20 months is this worker shortage issue. And we're working with other organizations to try and make this a federal issue, a state issue, really whatever you can. It's really just becomes a significant issue. But we're also then messaging to the community, hey, based on response volume, based on worker availability, what you may have expected to get a year ago or 2 years ago from your local EMS system, you're not going to get anymore, and just sort of deal with it. We've done that here. We've done a lot of media and community relations through September, October, when the call volume was super high. And we told our elected officials, we told our community stakeholders, we did media interviews and said, call volume's crazy. We've got 9% of our workforce that's out with coronavirus, Delta variant. If you stub your toe and call 911 or you have a minor ankle injury, it's same day service. We will get there sometime today. If you cut your arm off or have a heart attack, we'll be there in 11 minutes. We really need to prioritize calls differently. And you know what? People are okay with that. What we have found is if you're honest with them and give them the heads up that this is the challenge that we're facing, it's generally okay, and just change the expectation. And it's generally not the doomsday that you think it's going to be. In the presentation, you guys will get this. I'll include the part, Chelsea, that has the hot links. Several organizations are actually keeping a running log of all of the articles that are coming out about the workforce shortage and the worker crisis and finances and all that sort of stuff. So we can use that in some of our messaging in Congress and others. This is a joint letter that we worked on together with the American Ambulance Association to Congress. This got a lot of really good play for the American Ambulance Association. They were on Fox and Friends at some ungodly hour of the morning. Kudos to Sean Baird for getting up and doing that. But here's one of the messages, is that you can take the same messaging and try and do this at the local level or certainly at the state level. And we did that here in Texas. And we knew there was ARPA funds coming into the state legislature or into the state, and we knew the legislature was going to go into a special session for a number of reasons, but we really pushed very, very hard as a state association to the legislature and said, hey, take some of that ARPA money that you're trying to figure out what to do with and build up the EMS workforce. And we requested through a number of lobbying efforts, and there were a number of sponsors, co-sponsors on this initiative, $21.7 million for workforce development in EMS. And over the course of a 2-week period, because the special session was only 2 weeks, this passed at $27.1 million, exactly what we asked for, and the governor signed it last week. So this can be done at the state level. It can be done even at the local level, because there's a lot of federal funding coming around that could help with some workforce development. Vaccines, obviously still a hot button topic. And you saw recently that 22 states now are suing the Biden administration over the mandatory vaccine. But for EMS, we're sort of in this conundrum. Are we healthcare providers? Are we healthcare facilities that we fall under the CMS rule that if you're a healthcare facility, you must mandate that your workforce have vaccines? We did a survey of a number of different organizations. We had about 260, 270 responses. And there were a lot of people who said that they're not currently doing it, but they're considering it. And they are also very concerned about what's going to happen when they mandate vaccines. The workforce shortage may become exacerbated because now we've got to mandate vaccines in order to continue getting Medicare reimbursement or Medicaid reimbursement or federal dollars of any kind, including AFG grants and SAFER grants, and because all of that does apply. So it would even apply to fire services that don't do ambulance service because they get federal dollars. So this is something that we need to keep an eye on because it, again, could impact the workforce shortage. Now, supply chain, and y'all are in that supply chain, and we love you. And we need you, and you are between a rock and a hard place. We are between a rock and a hard place. The supply chain issue has become grave. And I know the REV folks, the Rev Group, are really in a pickle with ambulance chassis and chips and all the different things here. Our main office here is around several car dealerships, and it is still scary as all get out when you're coming to or from our facility and there are Ford dealerships and Chevy dealerships and Nissan dealerships, and there are a handful of new cars in the parking lot. And we know this continues to be an issue, but when you can't get ambulances because they can't get the chips and they can't get the chassis, it's a significant issue. We had an unfortunate situation here last week where one of our local fire departments had an accident on a highway and the box separated from the chassis and the box tipped over. Patient was on board. Thankfully, nobody was significantly injured, but the chassis was untouched. The box just came off the chassis. So when I pulled up to the scene and the fire department's EMS chief was there, after everybody was, fine and off the scene and transported to the hospital, literally the EMS chief turned to me and said, well, at least we don't have to replace the chassis because we're not going to be able to replace the chassis. And I said, Tom, that's a great way to look at the bright side because, the chassis was not damaged. The box came off, but, there you go. But that's how bad it's gotten. Because they had said, hey, we just placed an order for a new ambulance and we were told the chassis is going to take 18 to 30 months to get in before they can do anything with. So, and that's across the board. That's with, ambulances and ambulance chassis, it's medical supplies, it's PPE. It's just becoming a major, major issue. Kudos to Tim and Harry from Boundtree. They invited us to a discussion with one of our congressional representatives here in Grand Prairie, which is really a suburb of Fort Worth. So we're just going to call it Fort Worth, at their amazing facility in Grand Prairie. And their staff, the staff from Mark Vesey's office, was all about this. And they said, tell us how we can help you. We really want to do something because that is a significant issue and they know that it is, but that grassroots effort helps tremendously. Now, a lot of that was all doom and gloom, right? So you always have to look at the bright side or the calm after the storm. What this storm has done for this profession, for this industry, is given us permission to do things that 2 years ago would have been heresy, would have been unconscionable. So things like system redesign. In our system, and many systems are doing this now, we have been all ALS ambulance deployment for 36 years. Because of call volume, because of worker shortages, because of paramedic shortages, people going to work at the hospitals, we put a group together and said, hey, we need to stop doing all ALS. Clinically, it's not necessary. Operationally, it doesn't make any sense. And financially, it's killing us because we have to compete with the hospitals for paramedics. So we got permission from the member cities and from the first responders to literally put in a tiered response program using BLS ambulances. And this is happening all across the country. And if you ask those fire chiefs, EMS chiefs, community members, mayors, having this conversation 2 years ago would have never happened. But the coronavirus and all of the things that have happened because of the public health emergency gives you the permission to change your system design. And what this has done for us, and for every system that's done it, is dramatically increase the number of ambulance unit hours that they can put on the street, because now you can take 2 EMTs, put them on an ambulance and put them into the system. We typically at peak during a day deploy 54 ambulances. Today, literally today, 10 of those ambulances are BLS ambulances because 20% of our response volume has been designated by the medical director as eligible for BLS response. And doing system design things like that really help mitigate the worker shortage, the pandemic issues, but also are going to be long-term system change that needed to happen. And we all, for a long time, said, we really need to stop doing this all ALS deployment, or having in some states the requirement to have 2 paramedics on the scene of a call before you can initiate ALS care is just ludicrous. It's not based on clinical science. It's not based on anything. Well, now many systems are changing that. And this will be a good thing going forward because it really makes more sense to do that kind of stuff. I mentioned earlier the treat and refer. We've been doing treat and refer for coronavirus suspected patients since March of 2020. You'll see that in September, we were averaging about 7.5 patients a day that were falling into that category. Right now, it's a little bit higher than that has been in the past. But what that did is it allows us to generate data that we share with CMS, with our payers, with our community that says, it really is kind of safe to do this treatment in place thing, even without telemedicine, because it's standing order protocol, and it makes the patient happier. It keeps the hospitals from being overcrowded. And oh, by the way, it saves a boatload of money. So when you can generate that kind of data and show it, these are things that we can use federally and even at the state level for Medicaid to show that this type of service brings more value to the patient and to the entire healthcare system than just schlepping them to the hospital. What's interesting, and some of you may have heard this already, it's fairly breaking news. Last Friday, CMS sent out a note. Everybody's been struggling to get their ET3 model up and running. And one of the main stumbling blocks has been the ability to transport to an alternate destination. Many of the alternate destinations that were identified back in 2019 are no longer able to take additional patient volume from the EMS agencies. So after several conversations and some national phone calls with CMS, they issued this email to all the approved participants last Friday and said, yeah, you know, we understand that this transport to alternate destination thing is really a bugger. So if you can't do transport to alternate destination, and if that's a barrier to you launching your ET3 model, don't worry, launch, do transport to alternate destinations later. Treatment in place is okay for now, and you can just do that. This may help the 160 other agencies who went to participation agreements, signed participation agreements with CMS, but have not launched yet because they didn't have an alternate destination, perhaps, to be able to launch and by the deadline of 1/1 of 2022. So hopefully that will help. Now, in some states, they've leveraged the ET3 model to do the same thing in the state Medicaid office. So we did that here. Our state association went to the state legislature this past summer, and they actually approved and requires now Medicaid to pay for treat no transport. And the agency does not have to be an ET3 approved agency. It just now becomes the standard payment benefit that Medicaid pays for a response and no transport. Medicaid has already reached out to that association. We're working through the rulemaking process with them now, just because it makes a ton of sense. The other good news is that commercial payers, whether they're managed Medicare, managed Medicaid, or straight up commercial, have also caught on finally, and a lot of it because of what happened through the coronavirus, and said, you know, we're going to do the same thing. So we're going to, and we're contracting with them left and right so that these private payers are paying for those types of things, or those types of services, treat no transport. This one we're pretty excited about. This just happened in the middle of October. Our second largest commercial payer reached out and said, hey, we want to stop paying you to transport. Can we pay you for non-transport? We went back and forth, and look at the two things that are highlighted there. The AO427, which is an ALS emergency transport. So from a 911 call, they're going to reimburse us at $1126.75. That payment amount, by the way, is higher than they had paid us in the past for that same service. But the AO998 HCPCS code, which is ambulance response, treatment, and no transport, they're going to pay the same rate. So just like we worked with Medicare, they're going to pay the same rate whether we transport or not. Now you've got the commercial payers finally coming on board and saying, okay, we're going to pay the full rate because we really want to disincentivize you having to transport people in order to get paid. The other good thing that's happened is the ability for EMS to do more public health related things in the community, more healthcare related things in the community. So we, like many agencies, applied to our MAC, our Medicare Administrative Contractor, under CMS instructions to become a mass immunizer. It's a special designation. This allows us to submit claims and get reimbursed for doing vaccines and monoclonal antibody infusions. And the reimbursement isn't bad for that. So when we do a vaccine clinic, every person who comes, we give them the vaccine. We bill the commercial insurer $40. We bill Medicare $40. We bill Medicaid $40. Or we can submit, if the patient has no insurance, we can submit that claim to the HRSA uninsured portal, and they pay it. So it's a really good revenue stream, because when we do things like this, and we're doing them every week now, and we've got a vaccine clinic that we do 6 hours a day, every Thursday, 30, 40, 50, in some cases 100 people come through that clinic, and we've got a couple of EMTs that are doing these vaccines. It's great for the patient, great for the community. It's great for us because it's almost guaranteed revenue at a pretty high volume. One of our big managed Medicaid payers which is the Children's Health Plan, and they've got a lot of children's health insurance, a lot of CHIP members. They just literally reached out to us on Friday and said, hey, we've got 300 homebound kiddos that are on our health plan. Can you guys go out and do vaccines in the home? And while you're there, can you also vaccinate the rest of the family? So we said, sure. Are you going to pay for it? And they said, sure. How much? We told them what the Medicare rate was for homebound vaccines, which is $75. And they said, no sweat, just send us a spreadsheet when you're done. It's like, okay, this is again, great way for EMS to show more value into the community. These are some of our email exchanges with our large managed Medicare, managed Medicaid payers. Monoclonal antibody infusions, we're doing the same thing. We do them here in our special events building. We were averaging about 6 to 10 a day up until about 2 weeks ago. Now we're down to about 2 or 3 a day because the demand has sort of dropped off. But again, same thing. It's a $450 reimbursement to do a 90-minute infusion for somebody. It's a 60-minute infusion with a little bit of time front and back. But for EMS agencies that are looking for ways to augment their revenue and to become more valuable to the rest of the healthcare system, these patients that get referred to us for the monoclonal antibody infusions are coming from hospitals, they're first response organizations, and they're coming from payers who send their patients to us. So we're showing that additional value, that we're not just hook and haul, pay for the transport, there you go. And again, here's an example of one of our large managed Medicaid patients sending them over. I'm going to close with the other big thing that's happened is, you often hear the term, the enemy of my enemy is my friend. And we have formed an amazing collaboration with the American Ambulance Association, the International Association of Fire Chiefs, the International Association of Firefighters, and any EMT, and then others that may come in and out during those meetings. But we meet every other Friday, and we, with our legislative staff, with the volunteer leadership, and collaborate on high priority issues. And you know what? Most of the associations have the same position on those high issues. So when you work together, you're able to get a lot more done. Now, what's interesting is you also get a lot of attention when you do that. So NHTSA, other organizations who often criticized us, and even Congress, who often criticized the industry for being a little bit disjointed and everybody not being on the same page, they cannot say that anymore. And we can credit a lot of the legislation and a lot of the regulatory issues that have been very favorable to EMS to this collaboration, because we're all saying the same thing, we're all agreeing on the same initiative, and then we also agree on which association is going to take the lead on that issue. So in some cases, it might be the AAA, in some cases it's an EMT, in some cases it's the fire chief or the firefighters, and that's fine because we all have limited bandwidth. But let's at least not poke holes in each other's initiatives when we go meet with legislative staff or regulators. And that's worked very, very effectively. And in some respects, may have gotten some people a little bit nervous. Now, there have been also other collaborative initiatives. And one is recently there was a FICMS, and there is right now some FICMS listening sessions, the Federal Interagency Committee on EMS, which are all the different federal agencies that have a hand in EMS. And they're doing listening sessions, and at least they're listening to us. They've said pretty clearly, NHTSA and others, that there's no money that we're going to give you, but we're willing to listen to what your issues are, but we'll figure out the financing and maybe do some other things. But that has helped a lot. NHTSA has done weekly or every other week meetings with national stakeholders. That has been very beneficial. They're listening a lot. And that's okay. We haven't seen necessarily a whole lot of movement, but at least they're aware of what the issues are. In some cases, we've seen some really good things happen from the federal agencies. I will share this with you, that the one federal agency that has really, really made almost a 180-degree turn, and Kim Krennick might also weigh in on this, is CMS. Over the course of the last 18 months, the communication, the responsiveness, the outreach that CMS has done to the EMS community is phenomenal. And I've never seen it in 41 years in this industry. Phone calls, emails, even when you send an email to somebody and say, hey, I have a question, can we do this? And you get an email back within 3 hours. Like, seriously? CMS used to be like the black hole of questions and answers or whatever, but they're reaching out, they're asking questions, they're doing things that are different. Part of that could be the ET3 thing. Part of it could be the recognition that EMS really is a key stakeholder or a key provider in the healthcare system. But also, I think it's because we've been very responsive, that when they started to reach out, we got together, and Kim and everybody got folks together, and Chelsea and Charlotte got folks together, and the AAA and the NAEMT would host meetings for them. Has really been terrific. And that's going to be very good for our industry long term, because having CMS on your side is a lot better than not having them on your side. So that's been really good. So stepping forward, what we need to do is just continually protect our workforce. We talked about that. We often talk to people about how you have to create ways to have fun in the workplace. And we're helping a lot of EMS agencies with that, with some examples. Please work with us, y'all, on fixing the supply chain issue. It's not going away anytime soon. You know it better than we do. But I don't know if anybody watched the 60 Minutes report last Sunday. It's scary, and nobody's taking responsibility for it. They're all finger pointing, but we just have to figure it out. We have to continually prove that these enhanced services that we're doing, whether it's treatment in place, alternate destinations, vaccines, infusions, all that sort of stuff, is safe, effective, and saves money, and people don't die when we do that, that it's okay to send BLS EMTs to a call. It's okay to send a community paramedic to a 911 call if it meets a certain criteria, to do telemedicine and get that patient navigated. Don't even tie up the ambulance. Send first responders only, whatever that looks like. And then finally, just continue to collaborate. I know we're preaching to the choir. You guys at the CEC do a great job of collaborating with NAEMT already, but we know that a lot of the other associations are very interested in continuing that collaboration, again, because it's showing worth and is showing value, and it's working very, very well. Continue to support EMS. You guys all are. Thank you very much for being great community partners. And with that, I'm going to turn the screen back over to Chelsea.